Hi, this is Bob Harrington from Stanford University, and I'm really pleased that we're going to be hosting our second Back to the Heart of Cardiology conference with Medscape Cardiology and theheart.org in December. As a prelude to that conference, I've been having a series of conversations with colleagues who will be moderating and chairing the various sessions to try to share with our audience what exactly we're going to be talking about and what are some of the new topics that we're going to be pulling into the conference. So today I'm really pleased to have one of my friends and colleagues, Dr. Ann Curtis, with me. Dr. Curtis is currently a SUNY Distinguished Professor and the chair of the Department of Medicine at SUNY Buffalo. Thanks, Ann, for joining us here to talk about arrhythmias, antithrombotic therapy, some of the new things going on in AF.
Thank you. It's great to be here.
And let's start with sort of the combined story of antithrombotic therapy and arrhythmias. And let's talk a little bit about stroke prevention strategy in AF. You want to give us the current state of the state? How should clinicians be thinking about risk stratification and then embarking upon antithrombotic therapy for patients with either newly diagnosed AF or previously known AF?
Well, I think the CHA2DS2-VASc score still holds up pretty well with that. So as we know, it's congestive heart failure, hypertension. There are two age categories, 65 and over and 75 and over, diabetes, stroke or previous TIA, existing vascular disease, and then the sex categories, they say female, although that one sort of gets moderated now because the current guidelines say that anticoagulation should be given to men with a CHA2DS2-VASc score of 2 or more and women if it's 3 or more. For either one of them, if it's 0 or the only one that's a positive is being female, there really is no reason to use anticoagulation. And then when you get into the 1 to 2 range, it's got to be really a judgment call, informed decision-making with the patient to determine whether or not they would be better off starting anticoagulation now or waiting.
And one of the things that's coming out lately is that maybe a even lesser burden of AF is telling us something that we should consider anticoagulation. What are your thoughts on burden of AF that appears, for example, in the perisurgical period, in the hospital phase, and then seems to go away? How should clinicians be thinking about those?
Well, I think that AF burden is something to note. We're a little bit unclear about the real parameters for that we should be acting on. I think there's a couple of places where we have pretty good consensus. One is that if you're getting short runs of AFib, it's 15 seconds, that sort of thing, under 6 minutes. At this time, there really isn't a feeling that those patients need to be anticoagulated. I do enough monitoring to feel pretty comfortable with that. And to me, that would mean something longer than 24 hours, just to be sure I'm not missing it. For patients who have atrial fibrillation episodes lasting more than 24 hours, that's absolutely the kind of patient who should be anticoagulated if their CHA2DS2-VASc score justifies it. It's that 6 minute to 24-hour range that we're unclear about. There are some clinical trials in progress now to determine whether or not those patients need to be anticoagulated. So, until we know the results of those studies, I think you have to look at the patient and, again, try to assess risk of thrombotic events against risk of bleeding.
And there's been no question that oral anticoagulation for a stroke prevention strategy in AF is one of the most effective therapeutic interventions that we have in medicine. I think if you look at the original warfarin trials or the vitamin K antagonist trials against placebo, there's something like a 65 to 70% risk reduction in stroke. So clearly tremendous benefit to being on anticoagulants, as you say, when appropriate. The DOACs really changed the game, haven't they? The less stroke total, less hemorrhagic stroke, in some cases associated with improvement in mortality. Talk us through your thinking when you see a patient that you're going to be putting on anticoagulation. Do you reach right for the DOACs? Are there other things people should consider with vitamin K antagonists? How do you approach it?
Well, I think vitamin K antagonists should absolutely just not be used, period, unless you have very specific situations, the most common of which would either be mitral stenosis or a mechanical heart valve. You get into those situations, we don't have any data at this point that would say that a DOAC is safe. So those are the patients who need to be on warfarin. But pretty much aside from that, I think it's a direct oral anticoagulant you want to use. You mentioned some of the benefits of the DOACs. In addition, they've had a lower risk of intracranial hemorrhage, which is the most devastating bleeding complication you can get. So I don't really even think twice now. It's go straight to a DOAC. And then you adjust the dose if need be based on renal function. And there's some other parameters that are specific to individual direct oral anticoagulants.
When you have a patient that you've been referred or that you've perhaps been seeing for a long time, and they're on stable dosing of their vitamin K antagonists, in many cases, they've been on it for years. Do you make an attempt to switch them over and maybe help us with some of your strategies for conveying to the patient the importance of switching over?
There are many fewer patients like that today that I'd run into somebody. It's even just more complicated for the outpatient practice to keep track of these things. It's very inexpensive therapy. If I have a patient who's been very stable on warfarin, I don't necessarily change it, although I can't think of a recent case where that wound up happening. The more common scenario is that you do see the INR be labile. And in all of the clinical trials that have been done about anticoagulants, patients on warfarin stay in range something like 2/3 of the time. So I think it's something that's hard to count on. So there might be a few selected patients who are on stable doses and adequately anticoagulated, and they've been on it for a long time. There's really no reason to change. But it doesn't really take very much for me to make that switch over to the direct oral agents. And the patients are usually happy with it because it means fewer blood tests.
Yeah, that's usually the way I go first. I agree with you. There are fewer of these patients. I recently saw one that had been on longstanding oral anticoagulation referred over to me when his prior physician had retired. But I agree with you. There's less of them, and there's usually pretty compelling arguments to switch over, including when you say, "Look, you're not going to have to get these regular blood tests anymore."
Right.
That's usually the winner.
Mm-hmm.
We've talked a lot about antithrombotic therapy. Let's think more broadly about the issues of managing the rhythm of atrial fibrillation. And there's going to be a terrific talk given at the session by John Piccini on screening to rhythm control. So let's take that direction. Let's start with screening. And let me ask you the question. Are you seeing people coming in with their wearable devices who are referred to you because the wearable device picked up AF?
I should, but I haven't really seen many of those lately, I think, or really at all. So, and I think it's becoming easier and easier to screen patients. I think what we have to decide is, first of all, what kind of screening on a mass level do we want to do? And the other unanswered question is, are these patients who are asymptomatic simply earlier in the stage of AF and we naturally pick them up later? Or with the behavior of asymptomatic AFib or the need for anticoagulation and what kind of outcomes you would expect from somebody picked up serendipitously like this, would they be the same as the patient who comes in symptomatic, hospitalized with AFib, and you have to start treatment? So I think that's one of the unknowns that we have to answer is not only can screening pick these patients up, but if you pick them up early, does it make a difference in outcomes?
Yeah, great comments. Let's take the rhythm control piece, which, the mantra used to always be rate versus rhythm control, which is better. And then a large clinical trial suggested that there was not a difference necessarily between rate and rhythm control, but rate control looks safer overall. And I think a lot of us went to rate control unless the patient was symptomatic. But that seems to be being revisited these days with some newer clinical trials suggesting that perhaps more aggressive rhythm control leads to better longer term outcomes. You want to talk about your interpretation of the data and how you practice?
Sure. And I think that's true. I think a lot of us always suspected that it couldn't possibly be that easy, that simply controlling rate was going to be the way to go. And I think that has been proven out by recent trials. But I could mention one, East AFNet4, and that was a trial of early detected atrial fibrillation and whether a rhythm control strategy versus usual care was going to be superior. And the rhythm control strategy was superior in patient outcomes. But the thing I think it's important to note is that that wasn't simply an ablation trial versus usual care. It was rhythm control against usual care. And so patients could be treated with antiarrhythmic drugs and or ablation, depending on whether or not you achieved rhythm control. So, and in that cohort, only 19% of the patients underwent ablation by the end of 2 years. So what I took home from that is that it is better to have the patient in sinus rhythm. If you can get them in sinus rhythm and they stay there with an antiarrhythmic drug, that's good enough. If you can't, if they keep having recurrences, then you got to really start thinking about ablation. And the higher the AFib burden, I think the more you have to go there. Now, I don't have a good definition of that, but certainly if patients have AFib burdens of 1, 2, 3%, I don't really think that makes an impact. You start getting well over 10, 20%, or numbers that we've seen with things like PVCs, that probably would be more meaningful.
Yeah, I think that's good advice. As you've probably heard, there is going to be a big clinical trial led by the DCRI group and using Get With the Guidelines as the as sort of the data resource to identify people, collect data, and try to understand better the way to treat people who have first presentation of AF. So we've done the antithrombotic piece. We've talked a bit, not everything, but a bit about arrhythmia management. Now let's talk about a situation which is pretty common, and that's the question of combining antiplatelet and anticoagulant therapy in our ACS patients who have a bout of AF or our AF patients who present with an episode of ACS. Common clinical scenarios. A lot of clinical trials have been done looking at various combinations. What's your take home?
Well, I think the biggest thing I've learned from looking at these trials is that the risk of thrombosis from the latest generation coronary stents seems to be lower than we had in the past. Yet the bleeding that we get from these drugs hasn't changed. It's still a substantial portion of the patients. So as thrombotic risk drops and bleeding risk stays the same, that sort of pushes you towards being more conservative in how much antiplatelet therapy you use on top of the anticoagulants. So, we used to have triple therapy. We'd use aspirin, clopidogrel, and either warfarin or now a direct oral anticoagulant. Discussions about how long the aspirin therapy should go on and basically take out the clopidogrel and use dual antiplatelet therapy. Well, then that got truncated back to triple therapy just for a month and then discontinue aspirin at that point. And now the latest advice is that you can use aspirin in the hospital, but when you send the patient home, don't continue the aspirin. So go dual therapy right from the time of hospital discharge. That strategy seems to be associated with no higher thrombotic risk compared to what we've seen in the past and a lower bleeding risk. So that's really the direction we should be going in.
Yeah, I agree with your interpretation of a lot of trial data. And it's interesting that not that long ago, aspirin was sort of the one we never touched. That was considered to be foundational. And now we're finding out that the ADP inhibitor, particularly when you combine it with an anticoagulant, looks to be a better choice long-term, both from an efficacy and a bleeding perspective. So I think you're absolutely right. And it is a moving target, particularly as stent technology improves. And this has been a fantastic preview of some of the things that we're going to be talking about at Going Back to the Heart of Cardiology conference. I want to thank you for joining me. As a reminder to our audience, please do register for the conference in December. We look forward to all of the presentations and maybe more importantly, the robust discussions that I know we're going to have. So again, my guest on this podcast has been Dr. Ann Curtis. Ann is a SUNY Distinguished Professor and Chair of the Department of Medicine at SUNY Buffalo. Ann, thanks again.